Good morning, everyone. Thanks again for taking your time. I know how valuable it is to join us. So let me just give you a rundown what our intent was here. As Marty said, it's the follow-up from DBU, but we're hoping to expand this a little bit. So today we thought we'd cover the somewhat dry topic of clinical vocabularies, but the intent is not to make it super academic, but rather to be a lead-in to what some of your issues are, for us to tell you what we think some of the potential roadblock areas are, and it's often a topic that becomes more important as projects get started. So Wendy's going to share some real-life examples with you. And then the question is, do we need to go into a deeper dive into this topic in the future? And then what I'd like to get some feedback at the end is if this forum is useful, which I think it would be, can we do this on some regular basis, pick some topics, and have these kind of ongoing seminars, past maybe 30, 60 minutes, would give us a chance to get some feedback from you as well as present some information or even have some client presentations. So we'll make sure we get that feedback at the end. I'm going to jump right into this because I know your time is valuable. If you guys can't see our screen for some reason, let me know. And Kate, I can't advance my slides for some reason. Beautiful. Okay, hopefully you guys can see that. So just as a brief introduction, when we talk about semantics and DB motion, I'll remind you of a couple things. We look at the idea of aggregating data as sort of being dinosaur technology. The idea of just gathering information, most of you know, is a reason why you picked DB motion above others is because you realize that that's not good enough. So just getting all the information in one place is okay, but the next step is to be able to integrate that data, to be able to see it in a common viewer. But really, when we apply the semantics on top of that data, then we can actually apply knowledge, and we can understand things like what is diabetes, what is an ACE inhibitor, those kind of things that make the data much more interesting. All right, so the semantic content principles that we're going to cover here is that one is we want to cover all of the relevant medical domains, and when we talk about medical domains, we're talking about medications, allergies, problems, diagnosis, procedures, those kind of things. We're going to talk a little bit about what ontology baseline means. I realize that term may be formidable to some of you. We'll get to that. We'll talk about semantic relations, and then we'll talk about knowledge, how we gain knowledge by defining relations between domains. So what that means is, in a nutshell, is that we know a medication, for instance, is a diabetic medication. So we could link meds, problems, procedures, et cetera, with each other because they have a common concept. So I'm going to turn things over to Wendy, who's going to go through things, and then I'll join up again a little later.
Okay. So my goal is just to basically take everything back to a 101 kind of level where we kind of describe what do all these words mean, like ontology and semantics and interoperability. I think we use these words a lot, and like it says, it means many things to many different people. And if you're anything like me, it's one of those things that you think you understand, and then somebody says something that you, okay, maybe I didn't really understand what that meant. So if we have to look at what the definition of an ontology is, what components really put together this thing called an ontology, and it's these three things right here. So the taxonomy or terminology plus definitions, relationships to those terminologies and those definitions. Now, whenever I start to describe this, I'll describe each one in detail, but you'll see how things like SNOMED and RxNorm, they kind of fit into what I'll be describing is an ontology, but those unto themselves could be described as an ontology, but that's not where we're limiting. In DB motion, ontology is much bigger, and I'll kind of expand upon what that means. So the first part to having an ontology is basically just having a terminology. A list of terminologies is kind of like a basic component of what you need. So if you think about, and you'll hear the words control terminologies and standards, and I use these words interchangeably. They're synonymous. Some are, there's a list of medical ones on the right-hand side, and some are good and some are bad. But basically, all you need to fit the definition of ontology is a flat list of terms. Any standard out there, we're not just specifically speaking about medical standards. I have a 7.5-year-old daughter, and she would eat at McDonald's 7 days a week if I let her. She knows. I actually took her to Israel with me whenever I went over there 2 years ago, and there was a McDonald's over there. And she knew that when she was over there, she could get the same tasting chicken nuggets at the McDonald's in Israel that she could in the United States. And so that's a definition of what a standard is. Anywhere you go, no matter where it is, you're going to get the same chicken nuggets at McDonald's, despite what country or what state you're in. And if you go to Burger King, you're going to get a very different chicken nugget than what you're going to get at McDonald's, and she won't eat Burger King chicken nuggets. Now, transfer that over to medical standards. Each one of these on the list is a different standard, and we should be using, if you're using ICD-9 in Pennsylvania, it should be the same codes that you're using in California. They shouldn't change this, just because you're changing states or location. And so whenever you hear the word standards, it doesn't necessarily mean a baseline, but it's a controlled terminology. It's something that somebody's maintaining and should mean the same everywhere. So the second thing that ontology needs is definitions. And this is where some of those terminology lists kind of fall short. A good controlled terminology list should have very clear definitions. It's this idea of something called concept orientation. So a code in its description should be explicit. It should be very clearly defined. And there's different concepts that it should also have. So a single concept can have multiple names or synonyms. My husband woke me up about 2 years ago at 2 o'clock in the morning and said, "Wendy, I'm having a heart attack." And I said, well, he's a little bit older than me, but not old enough to have a heart attack. And I said, you know what, if you ever wake me up at 2 o'clock in the morning again, I'll kill you. So I went back to sleep. I wake up 2 hours later, and he's not in bed anymore. He drove himself to the emergency room. So I called him, and I said, where are you at? He said, my troponins elevated, and they're starting me on a medication called Integralin. Well, my husband's not in healthcare at all, so he didn't know enough to make that up. And of course, I rushed to the hospital. Well, fast forward, a couple of weeks later after all his tests are done, he had some sort of cardiac event where one of his vessels spasmed, and it caused a little bit of damage to his heart. But the point is and I'll to this day say he had a heart attack, but he keeps correcting me and says, no, I didn't have a heart attack. But the whole point is, what defines a heart attack? What is the word heart attack mean? Is it the same thing as a myocardial infarction? Is it synonymous? Are they synonyms of one another? And a concept can have multiple names and synonyms to one another. So the first example, hypoxemia and arterial hypoxemia, they're the same exact thing. What defines those two terms is exactly the same thing. The opposite of that, what we want to try and avoid, is things with a single name having multiple concepts. So you think of a cold. Are we talking about the feeling of being cold because the room is cold? Is it a common cold? What does the word cold mean? So if somebody comes to the ER and says, I have an infection of my fundus, I better know whether or not I need a gynecologist or an ophthalmologist, because those are two very different body parts. So one single name can refer to multiple concepts, and that's kind of what you want to avoid. So all of these terms must never be left up to interpretation, and this is where ICD-9 falls short a lot of times, because they have that not otherwise specified bucket where things go into and you don't know, there's no real clear definitions around what the meaning of those codes are. There should be no room for anybody to interpret those different ways. So if you look at the top right-hand corner of the screen, this is a screenshot from SNOMED, and you can see, if you've ever looked in their CliniClue tool, there's, up on top is all the different terms and the synonyms that it could have and the different types of synonyms, but it very clearly defines, it's a retinal structure, which part of the eyeball, things like that. Or if you look at the bottom left, we're talking about serum potassium, and there's a clear definition around it. It says it's a test. It's a specimen of, it comes from a specimen of serum, and it measures potassium ion. So there's no room for, is it coming from, is that a blood specimen? Is we measuring potassium in somebody's urine, something like that, sweat potassium. The next part is the relationships, and this tends to be the deal breaker in a lot of these ontologies, and where they fall short or where they kind of go above and beyond. So some of the ontology definitions. Now, whenever you guys are mapping to our ontology, whenever you're taking your local terms and mapping them to our baselines, we only give you the ability to do that equals to relationships. And that exists also inside of our ontology. We have lots of equals to relationships. But you can see there's a lot more definitions on this list. And just like a code needs to be very clearly defined, so do these definitions inside of the ontology. Direct parent class, what exactly does that mean when something contradicts, contraindicates, things like that, derived from. So one of the things Joel mentioned is the internal domain relationships. And these are things that dbMotion is not making up. And these are the things that we're taking from evidence-based medicine, standard organizations that already exist out there. We're not making this up. The example that I have here on the screen is Tylenol. And I use this because it's a very common one. It's kind of like one of those terms like a Q-tip where the brand name has kind of taken on the, the name of the product. It's no longer a cotton swab, it's a Q-tip. And Tylenol is kind of the same thing. You don't go to the store and, my husband goes to the store, and the dollar store. He doesn't buy acetaminophen. He actually goes to buy dollar store Tylenol. But in healthcare, if we're actually mapping our local concepts to this baseline standard, if you don't know that it's the brand name of Tylenol, you should not be mapping to the brand name of Tylenol. You should be mapping to the top concept, which is a different code. And it's acetaminophen, the generic name. But what's good is if you have something like a role that says, have my patients gotten an antipyretic, within 4 hours of them coming to the hospital, you don't have to map and query every single one of these codes. You can say, give me everything with the ingredient of acetaminophen. And that's where this other relationship underneath comes in. So the first has a relationship to the second, trade name of, bears a reciprocal trade name, things like that. All of those relationships exist inside RX norm. And so when we took our ontology, that's one of the standard terminologies that we took. So those three things together, the list itself, the taxonomy or terminology list, plus the formal definitions around those, plus the relationships, are what describes an ontology. So when you think about something like SNOMED, it has all those concepts. It itself is an ontology. RX norm, it also is a list of terms. It has very clear definitions and relationships. That is also could be an ontology. Where dbMotion, it has some of each one of those. Our terminology list contains a little bit from each one of those standards that I talked about. And the reason for that is if you look at something like SNOMED, SNOMED is a very good, rich, it's a good terminology. However, it doesn't have very good ways of defining lab codes. It doesn't have very good ways of defining medication codes. So you need those additional terminologies to be added to, we need at dbMotion to really have a good, rich ontology where we could, do a lot of these use cases that we're going to talk about in a minute. So if you look on our website, you see that we do semantic interoperability. So what exactly is it? And semantics isn't a word that's unique to healthcare. It's everywhere. And it's basically just the study of the words, meanings, and what they stand for. So what are these words that we're using in healthcare? What do they actually mean? The term semantic interoperability is the ability to allow all of your healthcare systems to interoperate with one another. And I think this is the next slide. No. So basically, it's the ability to have a patient with a condition in your outpatient, whatever system you're using, and be able to allow that to interoperate and have a lot of these, if somebody prescribes a medication that contradicts that condition in the inpatient side, you can get that alert on your computer, or you can get a smartwatch email or something like that, whatever the use case is. So it's the ability for your systems to interoperate with one another. Joel, is this you, if you want to keep going? Okay. So we didn't take when we build our ontology, it's growing every day, we're adding new concepts, but we didn't take everything into the ontology. SNOMED has probably 300,000 terms in it, and we clearly don't have that many inside of our ontology. So you have to start with basically what are the most frequently used. So what codes are people actually using? There are people that get their, they get excited because they find a code that doesn't exist inside of these terminologies, these standards, and they can submit it to the standards and have it added. But if it wasn't added and it's not already there, how often is that code really used? If nobody's missed it for that long, that you actually have to submit it. So when you're building an ontology, you really have to start with what's actually being used out there, not what's the rare cancer drug that might have been used once in the whole United States this last year. So this is an example of some of the data that we took from UPMC system. They analyzed the allergy codes that existed inside their database after like a certain amount of time, and they wanted to see what were the codes that were actually used. And you can see the first two, NKA and no known allergies, they're the same exact thing. Two different ways of stating that the patient doesn't have any allergies. Then you get down a little further, and penicillin, one's talking about the penicillins, like all penicillins, and one's talking about the medication. And so that takes you up to 53%. Of all of the allergies listed in a database, 4 codes can give you 50% of all of your codes. Now go down to the 95th percentile, and these are very rarely documented. They were documented 86 times in whatever time frame, and I want to say this was, you don't know the time frame, Jill, do you? It might have been a couple months. So it's not a whole lot of usage for some of these. Flavoring agent, I don't think as a nurse I've ever documented flavoring agent. Maybe a pediatric nurse might document something like that, but however. So if you map 600 codes, you can get 95% of all your codes used and mapped. So this is just whenever they were doing the analyzing what codes were actually used, you can see on the top the total codes used in DB Motion, how many codes were actually in the database times the number of times it was actually used. And you can see this is where we came up with our numbers to get to our basis when we first started this. Since time has gone on, these numbers have probably tripled and quadrupled, and we have a lot more than that in our ontology, but you can see the numbers really aren't that impressive. There aren't a whole lot of, there aren't hundreds of thousands of codes out there that exist inside of these standards. So when we talk about our baselines, and when I say baselines, I'm referring to specifically the baselines that exist inside of DB Motion. So when I say the word baseline, a lot of people will translate that to those standard terminologies or those, you know, like ICD-9. However, if it's not part of our ontology, we don't consider that a baseline. So when we say baseline, we're talking about the subset of those well-known standards that exist inside of DB Motion. We took those based upon the most frequently used concepts. Our clients that were actually sending data that were live and sending data into their databases, we took that from their databases and we analyzed it. And then we also did it specific to the use cases, so population health, like CHF use cases, diabetes, and you know, accountable care organizations. They have their disease population. So those are the ones we're starting with and building from there. And also to be compliant with the HITSB standards like C83, C80, they're telling us what standards we need to be using to exchange data with. So we also wanted to be compliant with them. Realizing that, we also have these out-of-the-box terminology maps. So ICD-9 is not one of our baselines. However, every single customer that I've come across so far, and I don't think we'll ever get away from this, is using ICD-9 and soon to be ICD-10. Well, with that, we don't want every single customer redoing the same work over and over. So as part of that, we built these out-of-the-box terminology maps. So we have ICD-9 codes already mapped for our clients to SNOMED. So you can still send us your local codes and your local terminologies, and we'll do that translation. There's nothing for the clients to do. We did that with ICD-9, ICD-10 eventually will be in there as well. I think in a month we'll have that. And there's a couple additional ones as well. So how does this exactly work inside of the application? So if you have your codes, these are, the green is supposed to be the baseline codes. So 4 milligrams of warfarin is very different from 10 milligrams of warfarin and 2.5. And each one of them has their code and its description with it. So our clients get the ontology, they get this knowledge already in there. We also have these things called groups, and if this was really reflective of what the product was, it actually wouldn't be as a warfarin. We know that that's warfarin inside our ontology. That relationship exists. However, you know, the grouping would actually be more like anticoagulants. So we know that these are anticoagulants. All warfarins are anticoagulants. We also have inside of the CTS all of this knowledge. So you can't see this inside of the vocab manager. If you looked inside the CTS, you'd be able to see all these codes and you know, their relationships to one another. So we have warfarin, we have trade name of Coumadin, then we have contraindicates and aneurysms, prevents pulmonary embolisms. All of those things exist inside of the ontology. So what we ask our clients to do is, you know, the red represents what the clients are setting from their local terminologies. We ask them, okay, take your local codes and map those to these baseline standards that we have. So with that, if you have a patient who's on warfarin 4 milligrams inside of EPIC, you can now see that it's contraindicated for aneurysms. So if you have that mapped to the baseline standard, and then somebody has, you have an ICD-9 code where someone diagnosed this patient with an aneurysm, you can then get an alert that says, oh, wow, these two are contraindicated with one another as long as everything's mapped to a baseline. So you can see how this CTS knowledge will then enhance the existing capabilities inside of all your electronic medical records. Same thing with Cerner. I don't know if you noticed that, but this EPIC outpatient system changed to Cerner, so it doesn't matter how many systems, you take those same codes from Cerner and map those to the same baseline. So you can then translate those EPIC medications into Cerner. So if you're doing like meds reconciliation, you can take your EPIC medications and push those into Cerner through that baseline, that translator of RX norm. Go ahead.
So I think the use cases that most people are familiar with, and again, just to go through them, are one is the concept of semantic grouping. So taking a bunch of allergy codes and being able to say all these represent penicillins or cephalosporins or sulfas, or these are all types of diabetes, all the hierarchy under there. The other example is the semantic export. So what we call local to baseline to local, but that means where the EMR is cooperative, that we can actually take an allergy or a medication from one EMR and with a single click send that to another EMR and have it be incorporated as if it was entered in that EMR's language. And that also is done on the fly. Some of you are familiar with our disease-specific clinical views, like a diabetes view. So, and many of you know we're trying to develop more of those. So the idea to be able to have, to click on a view that says diabetes and not have that hardwired. So tomorrow when there's a new diabetic med or there's a new diabetic concept that we may not even be aware of today, we don't have to rebuild that whole clinical view. In fact, the view always reflects what's in the ontology, and it makes that process very, very easy and cost-effective. And then as we move on to population health, as you guys know, how do we do that? So can we talk about a concept like diabetes? Can we talk about a concept, a simple concept like was a patient immunized for tetanus, and what does that mean when there's combination vaccines for tetanus or new vaccines with different names, et cetera? And then the final frontier, which is, as you know, analytics. What are we going to do with this data? And I think that's where most of the excitement is now. And as I talked about in the beginning, been there, done that. Aggregating data, okay. Being able to see it in a semantically organized way, okay. But what are we going to do with that data? And that's where we as a company believe the future is in using the semantic knowledge to do clean analytics. So just to give you some examples here, we're looking at a drug like ramipril, which is an ACE inhibitor. And what does that mean? Well, it means that it could show up, as you could see in the upper right-hand corner, grouped under a class called ACE inhibitors, that the EHR agent, which some of you have seen, can present data to us and not just flash every single time, but in fact can represent a class of medications, or the smart views like a diabetic view that you saw before. Other advanced functionalities that I mentioned, like population health, now knowing that this particular drug, ramipril, is a quality indicator for people with diabetes or patients with congestive heart failure, to make sure that that shows up on those lists of populations as a patient being on that drug or not on that particular drug class. And then having that show up on an analytic dashboard. How many of my patients in my organizations that have congestive heart failure are on a ACE inhibitor, and if ramipril was one of them, we would know that automatically, not again by mapping one-to-one to one. And then the other concept here is, yesterday's data should be understood tomorrow, and I'll have Wendy talk about that a little bit more.
Yeah, so they also wanted me to go over some of the common problems that occur whenever I'm out there helping clients map. So one of the common things that clients are coming across and some of the common problems, like why is this so complicated whenever we go to actually start mapping these terms, what makes it so difficult? And so one of the problems is that a lot of these terminologies and a lot of, not just the standards, the clients that I'm coming across, oftentimes they're changing the old code, to actually mean something else in the future. So a code that meant, one meant female 10 years ago, and now one is actually referring to a male. So when we get one inside of DB Motion, are we referring to male or female? And, how do we know that? So this is a common problem, and you see the example that everybody seems to know about is non-A, non-B hepatitis. The code over time has kind of changed the meanings. Whenever hepatitis C came out, it wasn't non-A, non-B, but they didn't have C as well. So what did that code mean? And over time you weren't really sure what you were getting whenever the data was actually coming across. A good ontology or a good terminology should never, ever, the code should never be deleted. They should never be changed. This is another common problem. NDC is a standard for medications, and it's maintained by the U.S. Food and Drug Administration. So it's a way of labeling the actual bottles that come across. So whenever I get acetaminophen, 325 milligrams, whether or not it comes in a 50 tab container or 100, is two different NDC codes, even though it's the same medication. So the actual product codes are actually set by the labelers themselves. So what they do is they have these codes. They have a standard for these codes. They have the 4 or 5-digit code for the labeler. The product code itself is 3 or 4 digits, and the package itself has 2 digits. Well, if a company, runs out of codes, they don't have enough underneath of, codes, and they have a new medication coming out, what they'll do is they'll say, oh, well, we don't make this drug anymore. We can reuse this old code. And unfortunately, there's still hospitals out there that might have that drug on the shelf where you can't really just get rid of it. And that's a big problem with NDC. You have 2 different NDC codes that are referring to 2 different medications. So that's one of the common problems that we come across. And how we deal with that, that's one of those gray situations. There's not a black or white answer. But it's a problem that NDC should fix, not necessarily our clients or DB Motion. The second problem, if you look back, this is another problem with NDC. I said 4 or 5 digits for the labeler code, and the product code has 3 or 4 digits. Well, what happens when you have, a labeler that has 5 codes and a product code that has 3, and they remove that first 0? So they usually have a little dash or something in between those different parts that separates each one of those, the labeler from the product from the package. Well, a lot of cases what's happening is if it ends in 0 or starts in 0, a lot of these computer systems are removing that leading or trailing 0. And so you don't get a 11-digit code. You'll get like an 8-digit code. And you've got to figure out, because it doesn't come with the dashes or it doesn't come normalized, what medication is it actually referring to, because you're not getting the hyphens or you're not getting the dashes. You're just getting an 8-digit code when it's supposed to be an 11-digit code. So where do you insert those zeros to kind of understand what medication you're talking about? That's a big problem that we have with NDC. And just so you're aware, if you have this problem, you can actually go on RxNorm's website, and they have some recommendations how to normalize these codes. But this is another big one that we come across whenever we're doing some implementations. The other very common one is ICD-9 terms, and there's a structure for ICD-9. I'm sure everybody's aware of it on this call, but there's 3 codes. There's 3 digits in front of the decimal point, and then there can be 2 digits afterwards. So whenever there's a 0 at the end, or you can see the last example where it's 038, a lot of systems are deleting that leading 0 or the ending 0, and so you're not getting the code that you expected. Well, if we have a lot of these out-of-the-box mappings, and our out-of-the-box mapping is 770.1, and you're sending 770.10, our system won't recognize that, and it won't do that automatic mapping for you. So what we receive inside our database has to be exactly what you're sending. So we need to make sure that we're adhering to the standard, and I believe the standard says it. I don't want to say this and be wrong, but I believe it says that if there's a 0, you remove the 0. If not, you don't. But again, we can only receive, or we can only map these automatically if we receive what we're expecting to receive. So another one of the common problems that's happening out there is overwriting code descriptions. And we have to remember that these codes and their descriptions, they're decoupled. The description of what the code's describing really isn't the code itself. So there was an example where we had a client, and 649.0 is the code for tobacco use disorder complicating pregnancy. So whenever a pregnant woman is smoking, a doctor would use this code. Well, whenever we're in Cerner, inside the hospital that I work at, I have to select a discharge diagnosis to get the patient out of the system. I have to. It's something that I'm mandated to do. Well, they don't have 17,000 ICD-9 codes in there. They have maybe like a couple hundred of the most frequently used. Well, if the code I'm looking for inside of that list, it doesn't exist, I pick the next one. Or I can get really lazy and just pick whatever from that list. And this is an example where they thought they were doing the right thing, but they weren't. So they had 6490, but what was happening is the doctors were deleting that complicating pregnancy part of it, and they were just saying tobacco use disorder to, give a code to one of their patients that was actually just a smoker, not necessarily a pregnant smoker. So they were, doing their smoking cessation with their clients or something like that, and they were using 6490 to mean tobacco use disorder. They were picking that code from the list and literally deleting the descriptions inside of the application that they were using. But what was happening was we don't get the description. The description isn't what the code means. I talked about the clear definitions that exist around those codes, and when we get the code 6490, it has to mean the same thing every single time. So, we'd get the code, and it came up because they were trying to do a use case about diabetes, I believe. But what they found was that they had 10 male patients inside their sample size because of these doctors that were taking and deleting the description saying complicating pregnancy and attributing that code to a male patient. So they thought that they were just using tobacco use disorder, where in fact it was a very different code. So we had 10 pregnant men inside of our sample set at that time. The other thing is, and this is a very common one, what means something in an inpatient system means something else in an outpatient system. So we have a procedures domain where we expect, if you look in like CPT's coding system, there's a couple chapters that are specific to procedures, which we think about like as surgeries and things like that. What we sometimes get inside of that domain, so we hook up all the interfaces, we start the data flowing inside dbMotion, and you can see inside of procedures domain, we get things like a complete CBC. That's a lab test. So a patient goes into his doctor's office, he gets a lab test. That stick that they do inside the office that they charge for, they're using it to charge to the insurance company, and that code is being reused to send information inside dbMotion, but a venous puncture does not belong inside of a procedures domain. So that's another big problem. We see the same thing with like problems in diagnosis. The definition of what is a problem and what is the diagnosis might be different from system to system, and oftentimes we get things going into the wrong vocabulary domain, and therefore it presents incorrectly inside the clinical views. You don't want to see a venous puncture inside of your procedures domain. You want that to flow into the labs. The other thing is underneath you see a problem. These are supposed to be representations of problems that exist, and doctors are using their systems in different ways. So they have a problems list where they have a list of what's going wrong with their patients, so they can just look at one place and see, okay, their allergies, their problems, everything in one spot, and they're documenting that the patient has an allergy to peanuts. Well, if they're documenting that inside the problems domain, it's showing up in the problems domain inside of dbMotion. So another doctor goes to look, and he looks in his allergies list. He's missing that peanuts allergy. He's not getting inside the right clinical domain. So again, when you go to do analytics, if someone goes, well, if it was an allergy to peanuts, it was an allergy to a medication, it would actually not do that alerting that you would need it to do. So it's another common problem, things like allergies and problems. So, and that's it. Those are just a couple examples of problems that I've come across. I don't know if anybody else had any examples or any questions.
So I think we're going to open up the lines at this point, and let's have your discussion and let us know our first attempt on this, too high level or granular in the future, and what are questions on we very quick. or let's hear what your thoughts are, questions, feedback, etc. So while Kate's attempting to unmute the lines, if you guys could use the chat function of the webinar, we could probably get some questions that way too. Okay, so I just heard that people that are on your computer should be unmuted. Unfortunately, we're having some technical issues with getting them unmuted. Questions out there?
Why don't we do this one? Folks have thoughts going forward. Feel free to email them to me, or Allie may have sent the invite. That's probably the easiest way. You know, our thought is this might be a good forum going forward, especially if we have topics that we want to hit from a clinical perspective. And we'll look for your guidance on. So with that, unless there are other thoughts or questions, why don't we wrap here, and we'll come back at it shortly after this. Okay? Thanks, guys. I appreciate everybody for joining the call. Talk to you soon.
Hey, thank you very much.
Thank you. Have a good day.